I used to do a bursectomy. As I said, I used to remove the pancreatic capsule and then bursectomy. And I mean, as per the recent literature, there's no difference between whether you remove the bursectomy or you don't remove the bursectomy. Rather, it adds to the duration of the surgery and some bleeding if you do a bursectomy. So we don't do now. So because the literature showed there's not much of an improved survival rate. And
Yes, sir. Literature-wise, probably it can help us in better staging, better lymph nodes as we go into that crevice, remove the nodes. It may help in better staging. Japanese again have proven that Western literature definitely yes doesn't support a bursectomy on a routine basis. If there is a serosal disease situated on the posterior wall of the stomach,
yeah, that's
it's
what
wise.
we used to do. Posterior wall, if it's infiltrated
Absolutely, yes,
beyond
sir,
that,
yes.
we used to do a bursectomy.
Yes, learning the technique is always good, sir. Whether we use it on see, I believe in using it. We try to peel off.
Yeah.
Sometimes I have to confess, it's not a complete bursectomy every time we attempt.
Yeah.
Sometimes we remove in bits and pieces. It will be adherent. We may not be able to remove in toto like an en bloc. But we have to taught the importance of bursectomy in case of a serosal disease.
Yes.
I agree.
Again, I would like to repeat the same question. I'm sorry to ask you again. I'd asked Dr. Palnivel, sir. Again, even though we depend mostly on PET CT or CT whether to know para-aortic nodes are involved or not. But in robotic or laparoscopy, so we don't do that much of extensive cauterization. What we were told is in open surgery, extensive cauterization till you see the left renal vein and sampling of all the lymph nodes. But that's not being done in robotics or laparoscopy. Or if it is all done, it's done at the end of the surgery once you do mobilize everything. So what is your take on this?
So routinely we don't sample the para-aortic lymph nodes. See, station 13 we sample in intra-aortocaval, in CAGB, in other malignancies, but in stomach we sample it only if it is enlarged. So going all the way into the station 16 and then sampling para-aortic nodes if it is not enlarged, is not a part of a pre-resection I would say step in gastrectomy. It is doable, definitely doable. So doing an extended Cocker maneuver, going on to the para-aortic nodes, intra-aortocaval group of nodes. When we are doing it for CAGB, we can as well do it for stomach also. It's not a question. It's a question. It's not about doability. It's about the usability as well as the need why we should be doing the para-aortic nodes. Of course, we need to have more studies whether the routine para-aortic sampling is required in an innocuous normal looking para-aortic. And normal para-aortic nodes, unless it's enlarged, sometimes may be difficult to sample also. So we don't at our center routinely do para-aortic sampling in operable non-para-aortic node not enlarged scenarios. Probably you can answer, do you routinely do it? So just for my understanding.
That's right. Our open surgery we do that. Yeah.
Yes.
We don't routinely do in stomach cancers because we rather depend mostly on the PET CT nowadays. But I agree with aggressive cancer like gallbladder cancer, yes. Because if it is positive, then probably your surgery of aggressive surgery is more futile. But in stomach, we don't routinely do a para-aortic as a sampling to take a decision whether you proceed with D2 gastrectomy or not.
But doing a para-aortic node sampling sometimes may be helpful. Now we are in a situation where oligometastatic gastric cancers, lymph nodes beyond D2, they are like para-aortic nodes, better controlled with the neoadjuvant. I should not supposed to be saying neoadjuvant, but in the curative intent, neoadjuvant treatments are being employed, like FLOT trials are also coming up in a big way, which can really reduce and then make all these nodes vanish after a neoadjuvant treatment. For that reason, definitely we need to know para-aortic sampling also. That's a different point, I would say.
Hi, Dr. Senthil. Excellent videos.
Thank you.
What is your experience on reconstruction? How often do you do J or S pouches?
Yes, literature-wise, there is no difference between Hunt Lawrence J pouch, we do Hunt Lawrence pouch, and a straight anastomosis. But having said, it's all cultural differences. We eat rice. We basically our bulk is more, or the quantity is more. So we most of the time we suggest a pouch, at least a double stapling. That means about 6 plus 6, 12 centimeter of a pouch, which can have definitely restore a little bit more of a reservoir when we do a total gastrectomy. Personally, we are in for pouch, but literature-wise, definitely there is no difference between straight and pouch anastomosis. It's
Yeah,
a
the
choice,
benefit
personal
is-
choice,
the
I
be-
would say.
The benefit is short-lived, because the studies have shown that
It
beyond
dilates.
1 year, there is no difference between
Absolutely.
pouch versus no pouch.
Yeah, but it distance. It somehow accommodates more food what we eat. Yes.
Both Kusheri as well as Hunt Lawrence.